Hello and welcome to Maritime Medicine Training. In this session, we'll be discussing vital signs. By the end of this session, you'll be able to identify the 4 core vital signs, identify the 2 ancillary vital signs, and identify and list normal vital sign ranges for the 4 core vital signs. You'll also be able to list the lower normal limit of pulse oximetry. Generally, we call them vital signs because they're vital. They are an outward sign of how the body is handling a physiologic event, and particularly the heart rate, but all of our vital signs respond to our internal physiologic status and are often a very early clue as to what's going on in the body. You'll obtain vital signs on all of your patients, and generally speaking, it's the trend of vital signs over time that matters more so than any one given set of vital signs. So our baseline vital signs give us a basis for comparison. One of the key principles of emergency medicine is that disease processes change over time, and the vital signs reflect those changes. So we get our initial vital signs, and then we look, are they improving? Are they getting worse? Are we helping the patient? Is the patient getting sicker? Now, sometimes the individual vital signs are important. If they're grossly abnormal, they tell you that the patient's in immediate distress. So, for example, I have a healthy 24-year-old falls and strikes his upper abdomen on a hatch cover. He has immediate pain. His first set of vital signs are a heart rate of 130, a blood pressure of 72/54, a respiratory rate of 28, an oxygen saturation of 92%. Temperature is 37.2 Celsius. This patient is sick. Those are grossly abnormal vital signs. He is clearly in a shock state and needs immediate resuscitation. Suppose I have the same patient, same injury. His initial set of vital signs are a heart rate of 94, blood pressure of 132/72, respiratory rate of 20, oxygen saturation 96%, and temperature is 37.2. He still has ongoing abdominal pain, and when I re-examine him half an hour later, his heart rate is 110, blood pressure is 134/72, respiratory rate is 20, oxygen saturation is 96%. So now I'm a little bit worried. His heart rate's going up, so I can compare that trend over time, and it may be that I just haven't controlled his pain. So I give him some pain medication, I reassess him in another half an hour. His heart rate is 115, his blood pressure is 120/64, respiratory rate's 22, oxygen saturation is 98%, and his temperature is 37.4. Now I'm seeing very aberrant changes in his vital signs, so it's that trend that's very important to me. So your 4 core vital signs are a pulse, heart rate in beats per minute, a respiratory rate, breath rate in breaths per minute, blood pressure, and a temperature. Additional vital signs or ancillary vital signs can include a pulse oximeter, which measures oxygen saturation of the hemoglobin, and we'll talk more about what that means, and a pain scale. And there's lots of places that we can check for a pulse, and a pulse is basically feeling blood flowing through an artery, and you feel the little pulse wave when the heart contracts, and then you don't feel anything when the heart relaxes. So if you're up by the head, you can check in the carotid arteries, and to check a pulse, you basically have to compress that artery slightly, and the artery is found in the groove between the larynx, the voice box in the center, and the muscles of the neck, so the sternocleidomastoid. So if you put 2 fingers, typically your ring and your index finger, onto the larynx and slide it down into that groove, press down slightly, you should be able to feel the pulse. And that's your carotid pulse. You don't push on both sides at the same time for 2 reasons. 1, if you push hard enough, you'll cut off blood flow. And 2, you have things in your neck called carotid bodies, and when you massage them, they actually slow down your heart rate and drop your blood pressure, and you don't want to do that. In addition, with any pulse, don't use your thumb. While all of your fingers have arteries with reasonable blood flow, your thumb actually has a fairly palpable pulse right on the pad where you would be feeling for an artery, so it can be a little confusing if you're feeling your own pulse or the patient's pulse. The most common place that we check a pulse, if we're just taking a pulse, is at the wrist on the radial artery, and the radius is the bone on the thumb side of the arm, when you're standing in anatomic position. It's on the lateral aspect of the arm, and it is in the groove between the bone and the flexor tendon. And you can see the red arrow labeled radial artery. You see that flexor tendon, which is about 1.5 centimeters from the edge of the wrist. And then there's the edge of the wrist where the bone is, and if you go between those two spots and push down, you should feel a pulse, again using the tips of your ring, or your index and middle finger. On the opposite side, you do have an ulnar artery. That's typically not checked for pulse. It's a little bit harder to find, but having said that, it is a good one to test in the event of an injury, and it's actually a little bit more medial than that arrow would suggest there. You also have pulse points in the femoral arteries, so the crease where the leg flexes up against the edge of the pelvis, and if you just put your fingers into that crease and slide them along, you should feel a pulse. That's a good area for assessing the patient who's relatively sick and you're off to their side rather than up at their neck. Usually you can feel those pulses at lower blood pressures than you can feel pulses in the radial artery. They're also important to check in any patient with abdominal pain or injuries to the abdomen or the extremities to make sure that they're present. You also have 2 pulse points on your feet, the dorsalis pedis on the top of the foot. Typically you can find that between the first and second, sometimes the second and third large bones of the top of the foot, starting on the inside, the medial side, and moving in. That's one that you want to assess for an injury. You would rarely take someone's pulse rate there. The posterior tibial pulse is right behind the medial malleolus, which is the lump that is the lower end of your tibia. And so if you go 1 centimeter down and 1 centimeter behind that and just kind of move your fingers around, you'll find a pulse there as well. And you would also assess that in an injury, or if somebody had a cold leg that was blue from a blood clot. The problem with those is that the older you get, the more the arteries in the leg stiffen up and the less you can feel pulses in there. So you may very well not be able to actually feel those pulses in older patients, just at baseline. So we express pulse rates and respiratory rates in a beats per minute or breaths per minute calculation. And typically we don't measure for a full minute, although if we want to get a very accurate number, we do. However, what we typically do is count for 15 seconds and multiply that number times 4. So normal rates, generally accepted normal rates for adults are 60 to 100 beats per minute. I personally would actually drop that lower limit to about 50. I see a lot of otherwise healthy adults who have heart rates between 50 and 60 who have no symptoms from it. But the technical definition of bradycardia, slow heart rate, would be below 60. Children, their rates typically 80 to 130 beats per minute, and in infants 120 to 160 beats per minute. And for children and infants, that's in a not crying state. When they're crying, those numbers go up. When they calm down, they come back down. In addition to describing the rate, we also describe the rhythm of the pulse. The rhythm can be regular, pup, 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 or it can be irregular. And if it's irregular, it can be regularly irregular, pup, 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 or it can be irregularly irregular, pup, 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 pup. And those mean different things about what's going on with the heart. So if you were to call me as medical control and say, I have a 62-year-old male with a feeling of his heart racing, his heart rate is 120 to 140, it's irregularly irregular, and his blood pressure is 110 over 72, I know that you're talking about a patient with atrial fibrillation with rapid ventricular response, most likely. And so just that simple information conveys quite a bit of information to me as medical control. So we've described the rate, we've described the rhythm, we also described the quality. And it's either full or strong or normal. So how do you know what that feels like? Well, you need to check a lot of normal, healthy people's pulses, and then you'll get that sense. From that, you can then determine if it's weak or what's called thready, or if it's bounding, which is essentially a pulse that you barely touch the skin and you can feel. And all of those things mean different things in terms of the patient's physiologic responses to whatever's going on in the body. We record respirations just as we did with pulse and breaths per minute. Normal rate for an adult is 12 to 20 breaths per minute. The normal rate for a child is 15 to 30 breaths per minute, and an infant 20 to 40 breaths per minute, and up to 70 breaths per minute right at birth. We also describe the rhythm of respiration. It can be regular, and it can be normal when it's regular, as you can see in the drawing on the right. It can be deep and regular, like the Kussmaul respirations. It can be regularly irregular. The Biots and Cheyne-Stokes are both regularly irregular. Cheyne-Stokes breathing can also be irregularly irregular, where that pattern on the bottom becomes less repetitive, and sometimes there's longer and shorter episodes of breathing. And in addition to the rate and the rhythm of breathing, we also describe the quality. Full breath is a normal breath. Deep breath is one that is deeper than a normal respiratory pattern, and again, you have to observe patients to see what normal breathing depths are. Shallow would be less than a full breath. Labored means they're having trouble breathing, and you can physically see difficulty getting the air in. Noisy, you can hear sounds as they're breathing, and panting is a particular type of sound, but it's a shallow, fast respiratory pattern. We also measure blood pressures, and that's measurement of pressure in the arterial system, and specifically the systemic arterial system, so from the left side of the heart out to the body. And we measure two numbers. We measure a systolic or upper number and a diastolic or lower number. And if you think about your arterial system, there's always some pressure in it. So there's a baseline pressure, and then when the heart squeezes, particularly the left ventricle squeezes and squirts blood out through the aorta into the body, that pressure goes up briefly. And then as that ventricle relaxes, the pressure returns to the normal baseline static pressure in those vessels. And so the systolic is the pressure during left ventricular contraction when all that extra blood is squirted out of the ventricle and into the arterial system. It's the peak pressure in the system, and it measures pump force against resistance. The lower number, the diastolic, is when the left ventricle relaxes. And so now that's the base arterial pressure, the static pressure. There's not blood pushing through. There's no pulse wave going through. It's just the blood sitting there, and it's a measurement of the pressure as the blood sits there. And that measures vascular resistance and the elasticity of the vessels. Now, to measure blood pressure, the most common method is auscultation, and auscultation means to listen. And so what we do is we put on a blood pressure cuff, and that blood pressure cuff is attached to a little gauge, and the whole thing is called a sphygmomanometer. And that little gauge tells you how much pressure there is in millimeters of mercury inside the air bladder. So the cuff goes around typically the arm, the upper arm, and you listen to the artery in the antecubital fossa, the area where the elbow flexes. And you inflate the cuff, usually to 180 millimeters of mercury or so, but you want to cut off the arterial blood flow. And you can listen to that area as you're inflating the cuff, and sometimes you'll actually hear the blood pressure in reverse as you're inflating it, but that tells you if you can hear the blood flow. So you inflate to 180 millimeters of mercury. Then you very slowly begin to release the pressure in the cuff, and that takes pressure off of the arteries. You're not going to hear anything for a while. And then when you reach the peak pressure in the system, you're going to begin to hear blood flow through the artery. Start with a knock, 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 and tch, 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 tch sound as blood flows through that compressed artery. And as soon as you hear the first knocking type sounds, that's the systolic blood pressure, the upper blood pressure. And the gauges are all calibrated in even numbers, so you're typically going to read an even number off. And you continue to slowly release air, and you should continue to hear that sound. And you'll hear that sound for a while because you're still compressing the artery. Eventually, the pressure in your blood pressure cuff gets so low that it reaches the static pressure in the arterial system, and then the sounds go away. They fade, so you'll hear and when you can't hear them anymore, that's your lower number, the diastolic number. So you basically inflate your cuff, you listen till you hear noises. As soon as you hear noises, that's your systolic number. You continue to listen as you slowly release the pressure. And as that fades away, when you can't hear it anymore, that's your lower number, your diastolic number. These can be done with machines as well, and those are very accurate. So if you have access to one of those machines, well, you should always get at least one auscultated blood pressure on your patient. It can be very hard in a noisy environment, and typically using a machine which doesn't depend on actually hearing transmitted sounds is a good way to follow those over time, and make sure that if you've got 2 or 3 people checking a blood pressure on a patient over time, that you're getting consistent and precise readings. Now, sometimes it will be too noisy to hear a blood pressure, and so you can do what's called the palpation technique. So you do the same thing with the cuff. You put it on the upper arm, and you are going to inflate it, but before you do, you find the radial pulse. And you can also do this on a leg if the patient's laying flat, and find a dorsalis pedis pulse or posterior tibial pulse. But you find your pulse point. You then inflate your blood pressure cuff until that pulse goes away, and then inflate by about another 20 millimeters of mercury or so. And then you slowly let it out, and as soon as you can feel a pulse returning, that's your systolic blood pressure. Now, remember, you could feel the pulse even when the blood pressure cuff wasn't inflated, so there's no way to measure a diastolic blood pressure doing this. You'll feel that pulse all the way down to 0 pressure in your blood pressure cuff. But you can measure a systolic pressure, and you can trend that over time, so that can be very useful. Normal ranges for an adult, the systolic is 100 to 140, the diastolic is 50 to 90. Your goal is less than 130 over 80. 130 to 140 over 80 to 90 is considered pre-hypertension, and some people actually would begin treatment at that point. But for you, you're not really worried about that. You're worried about grossly abnormal vital signs. So these are your normal ranges. In children, it's age dependent. Typically, it's 80 plus their age in years, plus or minus 10 to 20 millimeters mercury for systolic, and 40 plus their age in years for diastolic, and you can add plus or minus 10 to 20 on that as well. Measuring a true core body temperature is one of these great challenges in medicine. So we have a few accepted ways that we measure temperatures, and we recognize that there are limitations. You can measure temperatures in the ear, and while those work great in the labs, the equipment actually isn't all that great for use in the real world, so typically I wouldn't recommend doing that. You can do the scanners that measure the temporal artery temperature. Again, great in the lab, not so great in the environment you're working in. You can measure a temperature in the armpit called the axillary temperature. And actually, if you're using a continuous monitoring temperature, like an indoor-outdoor thermometer that you tuck the probe in the armpit, that's not a bad way to monitor somebody over time. As long as you keep that arm tucked against the side, you keep the patient wrapped in the same protective coverings, and you can measure a temperature in there, and you can see if it's trending up or down. It may not give you an exact temperature, but it's a good way to follow the trend continuously. We typically will measure oral temperatures, and that's a temperature under the tongue. And to measure that, the real secret is the patient can't have had anything to eat or drink for about 15 minutes to half an hour before you measure their temperature, because that'll change the temperature in the mouth. But more importantly, the tip of the thermometer has to be tucked way back into the little pouches under the tongue. And what often happens is people just put the tip of the thermometer right under the end of the tongue. And what you're really measuring there is the temperature of the oral cavity, which is typically lower than the patient's core temperature. You need to slide the thermometer back under the tongue until it's a little bit uncomfortable, till they feel a pressure back there, because now you're measuring a temperature near the carotid arteries, and that's coming right off the aorta and gives you a true core temperature. Rectal temperatures are also useful. They tend to lag behind other temperature methods because the rectum is farther away from the heart and the aorta. They blood flow to that part of the bowel comes off lower on the aorta. However, it is a good way to measure people over time. And the real key to that is you need to make sure that the tip of the thermometer is along the edge of the bowel wall and that you haven't put it into the middle of a ball of stool, because if you do that, all you're doing is measuring the temperature of a ball of stool. You need to be off to the side where you're measuring the temperature of the bowel wall, which is closer to the temperature of the blood in the aorta. Other methods that can be used are measuring bladder temperature or esophageal temperature. You typically would not do that in your environment. So our temperature normally varies in a fairly cyclic pattern, a circadian rhythm. And so it's highest in mid-afternoon when our metabolic rate is at its highest. It's lowest at about 4 or 5 in the morning, which is why if you're pulling an overnight watch, you feel so cold and tired at that time. It also will vary by the amount of activity that you're doing and other physical factors. And the normal range is 95 degrees Fahrenheit up to 100.2 or 35 to 37.9 degrees Celsius. Lower than that, we consider hypothermia. Higher than that, we can consider to be hyperthermia, or excessively high body temperature. A fever is a hyperthermic state, which is a normal body response to infection. So the set point of your metabolism is increased and your temperature runs higher. That's both a response to the infection and it can help your body to fight the infection more effectively. We know that in kids who we control their temperatures, their illnesses, viral illnesses in particular, tend to be prolonged, whereas if they're allowed to have the fever and not be given anti-fever medications, the course tends to be shorter. So we know that there's some way that the fever helps the body fight the infection. In heat stroke, your body loses its control of temperature regulation, and there the temperature goes up and up and up. And we see this in our patients who are high on stimulants. So when we had our bath salts epidemic, our very sick patients were coming in with temperatures above 110 degrees Fahrenheit. The pulse oximeter is another nice vital sign obtaining device, and what it measures is how much oxygen is being carried on the hemoglobin in your red blood cells. So the oxygen that dissolves in your blood really doesn't do much for you. It's the oxygen that's attached to hemoglobin that's so important. And so this infrared spectroscope called the pulse oximeter basically measures how much hemoglobin you have, and of that, how much has oxygen bound to it. And it gives you a percentage, and that's described as saturation of hemoglobin with oxygen, or oxygen saturation. And in a normal person, that's above 95%. So it's a useful tool for monitoring people that you're worried have low blood oxygen levels. It's also good for training over time, particularly if you're supporting somebody's breathing. You can see if you're effectively delivering oxygen to the blood out in the periphery, because you typically put this on their finger or toe or on their ear. The other nice thing about most pulse oxes is because they're detecting blood flow with the hemoglobin, they can give you a continuous pulse reading as well, so it's nice to be able to monitor that over time. So this is one pulse oximeter. This is a very nice one, and you wear it on the wrist. You can see that 98, that's the percent oxygen saturation. The 0.75 is the heart rate. And on the bottom, you actually see a graphical representation of the pulse force. And you can tell, looking at that, if it looks fairly flat, that you're not getting a good pulse ox waveform, and that means that your numbers probably aren't accurate. They will tend to measure low, not high. But with a good waveform like that, those are pretty believable numbers. Another vital sign of a sort is the pain scale. And we use this to monitor pain and to monitor patients' response to our treatment. Because if we're going to treat their pain, we want them to get better. Well, how do we know if they're getting better? Pain is not objective. It's a very subjective experience. So the patient needs to tell us that they're getting better. So no pain is a 0. Unbearable pain is a 10. And there is no number higher than 10. So 10 has to be the worst possible pain that the patient can imagine. Now, many patients have a lot of trouble quantifying this or understanding that upper limit. And so you may need to give them an example of what, for example, could be unbearable pain. such as if your fingernails were being pulled out, or if your spine was being ripped out of your body. Now, I say this sort of jokingly, but there are some people who will look at you, be perfectly calm, not in any apparent distress, who tell you that their pain is a 10 out of 10. And so you need to just confirm with them that, in fact, the worst possible pain you can imagine is, in fact, what their experience is at that point. Now, we've talked about a lot of numbers. Vital signs are numbers. They're objective information, with the exception of the pain scale. And they're very good in that they're objective information, but we treat patients, not numbers. So if a patient has a heart rate of 42 and they feel absolutely normal and their blood pressure is normal and they have no symptoms at all, and they're seeing you because they sprained their ankle, that may be their normal heart rate. And it may be that they're sprained their ankle because they're an ultramarathoner and they twisted their ankle, and they're just very, very healthy and very efficient at delivering oxygen to their body with a slow heart rate. So vital signs are one part of your assessment, and you need to think about them in the context of the patient's presentation. Please complete any knowledge reviews for this session, and if you have any questions, please contact your professor or instructor. Thank you.